And I'd like to call up the representatives to the main session table. The commenter for this particular case is Neil Schultz. And so we welcome Neil to give a presentation from the table, right? We're going to do it from up here? Yep, that would be great. Welcome, Neil. Thank you. Thanks for being with us today. We really appreciate it.
Good morning. I'd like to thank the ICER team, Steve Pearson in particular, for the opportunity to speak in reference to this important topic this morning. On behalf of Astellas and Pfizer, we're responding, obviously, to the review, the ICER review in non-metastatic castration-resistant prostate cancer. It's an extremely important topic to us. And while Astellas and Pfizer note that ICER's analysis supports enzalutamide cost-effectiveness, we continue to have concerns regarding the methodology that was utilized throughout this entire process. First, there remains no clear evidence that substantive learnings from patient engagement groups or clinical experts, such as the American Urological Association, were incorporated into ICER's process or findings. Secondly, we and other stakeholders previously noted abiraterone acetate is not approved by the FDA for use in NMCRPC, and there is inadequate data to support an evidence grade of B+ for its use in the NMCRPC population. Thirdly, wording within ICER's report suggests differences between apalutamide and enzalutamide, despite no direct comparison between these two agents. This is compounded by a lack of transparency regarding the high degree of uncertainty of specific point estimates used within the model. As scientific leaders with an ongoing commitment to patients, Astellas and Pfizer appreciate the opportunity for these comments, and we welcome ICER's feedback. Thank you for your time.
Thank you, Neil. We appreciate you being with us today. I might ask if there are, we have a little bit of time, if there's some time from Steve or the ICER team or any member of the CEPAC or our experts that we have for Neil and or any other topic we've covered.
So is this on? I just probably turned it off. Yeah, so this is a new format in terms of our having two topics on a day, so I think I'm going to moderate just the last kind of 15 minutes before we start moving, or the last few minutes until we start talking about the voting. So I just want to actually thank you for your comments, partly because they are among the briefest and most precise of any we've ever had. So be careful what you ask for, but that was great. I'm not sure why you thanked me in particular for being here, but that's okay too. So you mentioned findings that should have been included in the model that were not, that were either recommended by some groups. Could you specify, because I'd love to have Greg actually be it, or others to have a chance to respond. I'm sure we would have received that recommendation and had a chance to think it through. So do you remember which specific elements you thought should have been incorporated in the model?
Are you talking in reference to
your first point?
The first point?
Yeah.
There was some comments, I know, in particular from a representative from the AUA, the American Urological Association, that talked about specifically that they didn't feel engaged in the process or they weren't consulted. That's what we're in reference to.
Oh, I actually know that letter, and I bet David would like to comment on it.
Sure.
Yes.
The AUA did say that, and it was absolutely an oversight by ICER not to have spoken to the AUA. Unfortunately, at the time, our program manager for this project kept switching, and apparently no connection was made with them. And we apologize to them for not having engaged. That said, I would encourage all of you to read the AUA's complete comments on our website as to what they thought of our report. They were the most favorable comments we've ever received on a report.
Yeah, so that there weren't any specific elements in terms of data points or perspectives that they or others that I'm aware of thought should have been in the model that weren't. The other issue, I think you raised it, it is always challenging for us, but it's always our task to try to grapple with indirect comparisons because that's the question that clinicians and patients have, and it's certainly travels up to the payers questioning about how did two drugs that haven't been compared head-to-head in a trial, what can we learn from the existing data to try to make the best informed judgments we can? So we always wrestle with how best to try to do that, and I know we try to be as transparent as possible. So again, I'm not sure if you guys had any specific detailed suggestions on ways that that indirect comparison should have been made that weren't done, if there was an alternative approach to doing an indirect comparison, for instance, that wasn't attempted.
Well, I just think personally, myself and the team reviewing the report, that there's certain areas in the report where language goes back and forth. So meaning there's areas where it says these treatments are equal for X, Y, and Z, and then there's areas where different language is used that suggests differences. There was also an error we identified in the reporting of the sensitivity analysis that suggested a difference between the two treatments despite there not being evidence to support that. So I would just say the report should just be reread potentially for nuances in wording. That's
all right. Well, that's always an important comment for us to hear. And the council is familiar with the tension that you face because we will often present clinical evidence and ask you to judge whether it's adequate to distinguish between two treatments. And then when the modeling is done, decisions have to be made with specific inputs into a model that maybe from the trials that you feel kind of are close enough but not exactly the same. And yet if you put in specific data points from those trials, the model will obviously spit out results that aren't exactly the same, even if your judgment of the clinical information up front is that it's hard to distinguish between two or more agents. So if there are any questions that the council has on that aspect of this report, now might be a good time to bring that up, and we can reflect on it either with the manufacturer or the research team. Tim, would you like to, do you have a question or a comment? Oh, Eric. Oh,
yeah, so,
sorry.
well, that's right. That's, so one of my questions is, you know, clearly the assumption on price is an important one in terms of getting to the quality side. And so my first question, you know, to you is the price estimate that's included in the model for enzalutamide reasonable from your perspective? I mean, it's an important input into the model.
I can only comment that our prices are public, our WAC prices are public. ICER, to our knowledge, and I think what David and Steve commented on, they use a proprietary database to include a specific price in the model. And so they didn't specifically ask us if that was the correct price. Like that question didn't specifically come, but what I'm saying is they use
I'd like to ask that question. You don't have to. I mean,
I can't comment.
That is the question I'm asking.
I can't comment on drug pricing.
Okay.
I would say, although I don't think we asked, is that the correct price? We did say, if you will send us the net price, we would use it. So that is part of our data request, is to get the net price, and we will, when given that, including now, between now and the final report, if you send us what the appropriate net price is and allow us to cite it, we will use that in the report as we have done in other reports.
And I also want to just thank you, and I appreciate your comment regarding the comparison between the two. I think it's a fair criticism, and I know that we read the report with a high level of criticism to avoid that, but you can even feel and see in the conversation that has happened today that happens, right? And it's not by malintent. I don't think that anybody, I think we all recognize, and I think multiple people, you know, the science behind this is that these are two separate analyses. There was no head-to-head comparison. So I think it is important as the final draft of this report comes out that we're very attentive to that, but you could even see it in some of the comments of the panel today that we frame things a little bit in a way that's unfairly, you know, it's not intended to be a head-to-head in any way. But I appreciate you raising that point because I think it's very important.
So I think to kind of pick up on that, and then to both Greg and to David, when you ran the models, I heard you say that in one of the models you took out the time to symptomatic progression. were the other models, which would have then focused it more on, the individual trials, were the models run basically using the individual trial data for each drug, which would kind of, I guess, get at Neil's question. And then additionally, I think it was brought up earlier about adding the time more likely to be on the drug, which would affect the cost in that. Do you have a guesstimate of what that would do to your overall cost effectiveness? If you went from 18 to 40 months?
Well, is this on? Yeah, that would increase the ICER for both drugs if we were to tie time on treatment or treatment duration to for instance, the time in the metastasis-free survival state. And, after that question was asked and we moved on to another question, I remembered from a few months ago that was originally how we modeled the time on treatment. And we did have much higher ICERs. And then we got a lot of pushback from the manufacturers that, well, this is the actual duration of treatment as reported in the trials, and this is what you should be using. And so there's some back and forth, but ultimately we decided to grant them that and base the duration of therapy on what was the median duration that was reported in the trials.
But the ICER that
ICER
you
would go up.
used, or the models that you used the separate trial data, so that would be a reasonable head-to-head, if I might say that, comparison of that. It gets. I mean, it's not like you're using trial data from one drug and adding it into your model to the other, particularly when you pulled out that
Right.
symptomatic.
Yeah, I mean, the metastasis-free survival curves, for instance, are modeled independently of one another based on the hazard ratios reported from the individual trials. Overall survival, which does have a big impact on the results, but I mean, that's similar because we had to make assumptions for overall survival based on the real-world data, and we didn't differentiate between one drug or the other. Is that getting to your question? Okay.
I just wanted to say, I mean, since it sounds like somehow either in the report or here today it didn't feel clear enough, I do not think we have adequate data to be making clear comparisons between these two drugs. The populations are not absolutely identical. They're very similar, but they're not absolutely identical. The PSA doubling times are a little bit different between the two trials. The definition of metastasis-free survival is a little bit different between the two trials. And even if all of that were identical, absent in a head-to-head trial, given the very small differences that we're seeing, I wouldn't trust that. So I don't think we should be looking at this. We gave an I rating for our ability to compare those two drugs. That means we think the rating is I, not we think you should be looking at these numbers and believing that you can tell the difference. We don't think you can tell the difference. I don't sort of know how stronger to say it than that you all will feel comfortable with. We don't think we have adequate data, and I suspect that even with long-term follow-up, it may be very hard to tell. I would encourage manufacturers to perform head-to-head trials so that we can know the answer to this question. We need head-to-head trials to answer questions like this. I'm really glad the Japanese are doing a head-to-head trial between abiraterone and enzalutamide. That still won't tell us about apalutamide.
So, David, I guess that's where I struggled just a bit with your A rating for each drug, because it seemed in part, and I can appreciate why you're trying to mentally do this indirect comparison and, the indirect chain of evidence. But then when I hear those kind of comments, I hear you kind of saying, we don't want to really compare them. And that's, yet you gave an A for each one of the drugs. And that's, I don't know how big of a difference that makes in anything we say here, but we're basically rating it on a single trial for each drug, and then well, they're similar enough, and I'm seeing this for that, and I'm seeing that for that. So mentally, I think in your presentation, you sort of said, well, it makes.
I don't mean to suggest that I don't think we can use the data from each to think about the other. What I don't think you can tell from this is if there is a small survival benefit difference between these two drugs. I don't think you can know that from Spartan and Prosper, and I don't think you could know which direction it goes from Spartan and Prosper. I do think that these populations are similar enough that it's fair to use each androgen receptor inhibitor to make you believe that it is likely that both androgen and receptor inhibitors work. That's all I would say on that, and that's how we got to the A rating. I also grant that people could come to a different rating on this, as often happens in the evidence-based medicine world.
So from a process perspective, I know we have some more questions. I think we're going to shift into the questions directly related to the votes, which I think many of these probably are. Thank Neil for your comments. You can have a seat back in the audience, and we're going to have Matt come up just to make sure that you guys are logged into the voting machinery before we get started.